My name is Dr. Jeff Matous, and I'm a member of the Colorado Blood Cancer Institute in Denver, Colorado, and part of the Sarah Cannon Research Institute. And here at ASH 2023, on behalf of my colleagues who are international, I'm going to present results from a phase 1b trial of the MonumenTAL-2 trial. And this is a study studying for the very first time the combination of pomalidomide and talquetamab in patients who have relapsed refractory multiple myeloma. And I think the results are very exciting. And so what we did in this study is we enrolled patients who had recurrent multiple myeloma who had had at least 2 prior regimens, including a PI and an IMiD. And patients on average had about 3 prior regimens. And so patients could also enroll if they had prior pomalidomide or even prior BCMA T-cell redirecting therapy. And so 35 patients were accrued. The talquetamab schedule was weekly or biweekly, and roughly half the patients were enrolled in each of those 2 schedules. The follow-up with the weekly schedule is much longer than with the biweekly schedule. And patients started on the talquetamab for the first cycle, and pomalidomide was added with cycle 2 at a dose of 2 milligrams. And investigators had the option of increasing from 2 to 4 milligrams if they so desired for the pomalidomide. And we'll discuss what the implications of that were in a minute or so. So to jump ahead, the results of the study I think are very impressive, and in my mind demonstrate the most potent combination of pomalidomide with another agent that we've ever seen in clinical medicine before. So responses were about 90%, and with the weekly dosing, complete responses were 65%, with several of those being ongoing stringent complete responses. And so I think that's very, very, I think, encouraging data looking at this combination. Now, what about side effects? Well, first for hematologic side effects, when investigators tried to increase the dose, and about half of them tried, of the pomalidomide from 2 to 4 milligrams, a lot of times they encountered neutropenia, and in fact, about half of patients who had pomalidomide required dose modifications, and most of those patients were those where we tried to go from 2 to 4 milligrams. Now, the talquetamab had the typical talquetamab side effects with the GPRC5D target of dysgeusia, skin toxicity, nail toxicity, and so forth. But these were generally manageable, although about 3/4 of patients with talquetamab actually had dose holds to manage the side effects, primarily dysgeusia, and about half of patients required modification of the dose of talquetamab because of certain side effects. The responses that we talked about before were durable. Most patients that were in had good responses, maintained them beyond 6 months. Follow-up continues for these patients, of course. With respect to cytokine release syndrome, or CRS, it was typical. It was about 3/4 of patients, and mostly manageable grade 1 side effects. About 45% of patients received tocilizumab. Discontinuations were very rare. Only 4 of the 35 patients discontinued. That was 11%. And so I think here we have the combination of a really effective IMiD, pomalidomide, combined with talquetamab, resulting in durable responses, manageable toxicity, and we believe that this warrants further investigation in the treatment of patients who have relapsed refractory myeloma.